Now I will invite Dr. Ben Rogers. Ben, as many of you know, is an infectious diseases physician at Monash Health. He's a real leader in the infectious diseases research and is collaborating on some very important studies on durations of therapy, particularly for bacteraemias. But we've asked him to talk about what is the duration of therapy for sepsis too short. Thanks, Ben.
I'm an infectious disease doctor and researcher from Monash Health and Monash University in Melbourne. Thank you so much, Jason and the organisers, for asking me to speak tonight. I'm sorry I'm doing this as a pre-record because it really looks like an amazing program and I wish I was there to hear the other talks. So I'm talking tonight about really the duration of antimicrobial therapy for sepsis. The topic I've been given is when is the duration of therapy for sepsis too short? I'd like to acknowledge the traditional owners of the land from which I'm speaking. I don't have any relevant disclosures tonight. So I'm going to start by asking you all a question because this isn't live, we can't do an audience poll. So I just want you to take the answer and park it in your mind. Think of the last time you went to a GP and got some antibiotics, skin infection, urine infection, something like that. And now I want you to think about how long you took them for. You would have got a course of therapy and how much of that course you took. Now, when we ask this question, people tend to divide into kind of 4 categories. The first category, which I must admit includes me, is the whole course. If I get 5 days, I take 5 days. I do what the doctor says. But not everybody does that. So a number of people will stop taking therapy when they feel better. Others will need to cease the therapy because of side effects of some sort. And a number won't start therapy at all. And I guess that the sentence that's missing from that is, and they're still here. You know, despite not taking the antibiotics, they've managed to survive their diagnosed bacterial infection. So this is a relatively easy question. How long did you take the antibiotics for? But in fact, the harder question is which of these is the best answer? Another way to ask this is how much antibiotic do we need to treat an infection? How long do we need to treat it for? And this is really a Goldilocks question because we need just enough antibiotic to control the infection, but no more. And just enough tends to mean different things in different patients and in different sites of the body. And this is one of the great challenges. So I'm an infectious disease physician and I treat a number of different complicated infections. And the approach is different. If we're treating an infection in a previously sterile site, such as the brain or the heart, you know, we want to treat that site right back to sterility till there's not a single bacteria left where that infection started. And, you know, that might take an extended course of antimicrobial therapy. However, if you're treating or I'm treating an infection that's, for instance, a ventilator-associated pneumonia or a colitis or something in a site that didn't originally start sterile, then the aim's quite different. The aim is not to get that site to sterility, but more to get the bacteria back into that primordial balance. To use the lay terms, it's the balance of the good bacteria and the bad bacteria. But really it's about getting that pathogen down to a level where it can be held in check, you know, by the body's immune system and natural mechanisms for, you know, controlling bacteria at sites that aren't sterile. So that's a very different proposition to an originally sterile site. So keeping that in mind, I guess we can ask, well, what happens if we don't get the duration right? If we give too little antibiotic, the obvious thing that can happen is the infection doesn't get better. You know, we treat the patient, but we don't treat them to a point when they recover. The patient can also have relapse after we stop the antimicrobial therapy. And the patient can also, or there is a concept that we might end up with resistant bacteria by not completing the course of therapy. And this is actually a very long-held concept where as we treat an infection, gradually the bacterial load reduces, till it's just the resistant antibiotics left. However, this really has not been borne out by studies. And this is probably, I guess, an age-old belief that is not really based on science and something that we probably need to move away from. But anyway, there are certainly complications to giving too little in antimicrobial. And I will also say that in these times where we've got such exceptional medicine and we have such good outcomes for the majority of our patients, I think society's acceptance of failure and relapse is quite low. You know, our tolerance for this is low. We expect that when we get an antibiotic or when our loved one gets an antibiotic, they will get better and the infection won't come back. And that's probably an attitudinal thing that we need to think about as we look to study this area more. So if we give too much antibiotic, what can happen? Now, this is pretty well described. You know, we clearly expose the patient to more side effects. We give them a greater burden of therapy. We absolutely, definitely select for antimicrobial resistant bacteria. So whilst that concept of not finishing the course is not borne out by science, there's plenty of good data to show that the longer you use antimicrobials for, the more likely you are to get antimicrobial resistant bacteria. So this is a truth. Patients at risk of Clostridioides difficile and other infections associated with antimicrobials. And they're also at risk of complications of the therapy that we're giving. So be that toxicity for the therapy or complications of the intravenous access. And the longer we give this for, the more complications they're at risk of. And obviously the higher the cost of the course of therapy. So really, this is a balance, and there are two sides to this coin, both of which have potential downsides. So this is the pros and the cons, but what do we actually know about this concept of the duration of antimicrobial therapy? Well, we know a bit. We understand the foundation of it. We know what needs antibiotics and what doesn't. And probably over the last few decades, we've actually become a lot better at knowing that than we were, say, 20 or 30 years ago. We understand what is and what isn't a bacterial infection in the majority of circumstances. For many of these conditions, we actually know which antibiotics work well. There's been good clinical trials of therapy of a number of infective conditions, and a lot of this data is very elegantly distilled in the Australian Therapeutic Guidelines. We're incredibly lucky in Australia to have such a good book to really guide clinicians to the best therapy for a variety of bacterial infections. And for some sites of infection, we actually have really good data on the duration of therapy, and I'll talk about that in the next slide or two. However, for sepsis and bloodstream infection, we really do not have good data on how long we should be treating patients for. So there is strong clinical evidence on the duration of treatment for a number of sites of infection. Pneumonia is a really good example. Over the last decade or two, we've seen the duration of therapy recommended for pneumonia come down and down and down, from 2 weeks to 10 days to 1 week to 5 days. And there are even some studies showing 3 days of therapy now. And this has really been through, sequential clinical trials, really showing that we can bring the duration of therapy down. Surgical infections of the abdomen that have been managed well, very nice studies showing these don't need much antimicrobial at all. Quite a contrast to what we used to do previously. Even for urinary tract infection, the most common human bacterial infection, we have some good data, especially for particular antimicrobial classes such as fluoroquinolones, showing that we can use really short courses of therapy. We also have data for less common infections, bone and joint infections, heart infections, central nervous system infections, really informing us around the duration of therapy we need. Some of these are very long durations, and it's potentially possible that we might be able to shorten these a little bit, but we do have a reasonable understanding of them. But for bloodstream infection and sepsis, it really is surprising that we don't know more. We know that about 1/3 of septic patients will have a bloodstream infection, and almost all patients with a bloodstream infection will be septic. And in fact, the mortality of bloodstream infection, depending on how you look at it, is somewhere about 15 to 30%. So this really is a group of patients where we should know absolutely as much as we can about how to treat them to make sure they have the best outcomes possible. So what we know so far, for a subset of types of bloodstream infection, we know a little bit. So for Staph aureus or golden staph, we have data informing us on a minimum duration of therapy. Maybe about 2 weeks is the minimum, or there's an increased risk of relapse. For other less common and boutique infections, we have similar data, such as Candida and a couple of other rare bacteria. We understand the duration of therapy a little bit. As I mentioned, for urinary sepsis, especially treated with fluoroquinolone antibiotics, there was a recent study on this. Regardless of whether the patient is bacteremic or septic or not, we know that you can use a short course of therapy, about 7 days of therapy. But for all these other infections, including urinary infections not treated with fluoroquinolones, and all of those other bacterial infections that you might see, bloodstream infections, we are almost flying blind. We don't have effective data to inform us on the duration of therapy. And we don't know whether the duration of therapy that's used for patients without bacteremia applies to patients with bacteremia. And one of the reasons for this is a little bit historic. Many studies have looked at the duration of therapy. And in fact, this is a little bit old now, but 2011 meta-analysis looked at 24 studies in this area. They looked at almost 8,000 patients randomized in these studies to different durations of therapy. But of these 8,000 patients, only 155 had bloodstream infections. And that's because historically, as these studies on duration of therapy have been conducted, patients with bloodstream infection have typically been excluded as the sickest patients that they didn't want to trial these shorter durations of therapies on. And moving forward in the future, hopefully this won't happen, so we start to get this information back on all patients with a given infection, not just those without bloodstream infection. So we definitely need to know more. We do know a little bit about what we do in Australia at the moment, and I think this is informative for us. And what we actually do is this. We tend to treat patients either in durations of 5 days, the number of fingers on our hands. If only we were Dr. Nick, we might treat patients for a little bit less time, or 7-day intervals, numbers of days of the week. We've looked at this at our hospital, Monash Health. Michael Birrell, one of our registrars a few years ago, looked at almost 600 episodes of E. coli bacteremia. The most important thing to know is all these patients were septic, but they were an incredibly diverse bunch. They ranged in age from 20 to 100. They had more than 7 different types of infection, and they were treated by 30 different teams of doctors. However, the vast majority of them got exactly 14 days of therapy. And this is pretty remarkable. I think it's not a far stretch to say that given the incredible diversity of patients and diseases, they can't all have needed 14 days of therapy. And we can do better than this. We also undertook a national survey based on a Canadian survey, giving 5 scenarios of 6 septic ICU patients with positive blood cultures to infectious disease and ICU specialists in Australia and New Zealand. It was Mostafa Alwan, a surgical trainee, who undertook this work. And in fact, the headline finding was that we all thought that patients were usually treated for too long. But when we got down and we asked these kind of 200 people how long they treated these different infections for, and these are all on the same scenarios: bloodstream infection, pneumonia, urinary sepsis, abdominal and skin and soft tissue infection. What you can see from these violin plots is that there was a huge range of answers, clustering around 7 days and 14 days, sometimes 10 days. But really, despite looking at exactly the same scenario and exactly the same patient details, people really gave very diverse answers. And to me, this means that as clinicians, at the moment, we really don't have the information to be specific about how long we treat patients for. We don't have the knowledge and the data to do that. So coming back to the original question, the question that Jason posed for me for this talk, when is the duration of therapy for sepsis too short? And I guess I'd say at the moment, too long is probably more of a problem than too short. Patients tend to be treated in fixed intervals of 5 or 7 day blocks. we do know there are really clear benefits if we can reduce the duration of therapy. We also know that there are risks if we reduce the duration of therapy. And ultimately, what we should really be aiming for is probably a bespoke duration of therapy, a duration of therapy customized for each patient, based on the site of their infection, the pathogens involved, the patient's immune status. Potentially, new technologies and other tools could help us. There's a lot of data on biomarkers, but it's probably a whole other talk to really talk about, how these could be used. One of the promising things for us is that some research is on the way to inform us. Now, there are a number of research studies ongoing on this, but I'm just going to talk about one that I'm involved with called the BALANCE study. This is led out of Canada, but it's a global collaborative trial, and it's a very large randomized trial of critically ill patients with bloodstream infection, about half of whom will be in ICU. The patients in the BALANCE trial are randomized to 7 or 14 days of antimicrobial therapy. Now, we're aiming to include 3,600 patients. We've already enrolled over 2,000 patients. So this trial is going to give us a nice chunk of solid data about the duration of therapy in this cohort. We have funding to enroll 800 patients in Australia, and we have some incredible sites that are enrolling patients, really enthusiastic, all over Australia, randomizing patients to 7 or 14 days of therapy. And it's just amazing to see that happening at the moment. So to wrap up this talk, when is duration of sepsis for therapy too short? I think this is really a difficult question at the moment. We know that a reduced duration could have some benefits, but at the moment we really lack quality data to know how short we can get that duration and who we can reduce the duration on. There are clinical studies ongoing in this, including BALANCE, which I'm involved with, and other trials, and these will improve our practice moving forward. We're in an age in the next decade or so where we'll really be getting more and more information on this. That's all I've got to say tonight. Thanks so much for listening to me. Thanks so much to Michael and Mustafa, who undertook some of the research that I presented. And this is the team that are involved with the BALANCE study in Australia, and all the participating sites and investigators and patients and families as well. Now, that's my email address. I'm really keen to hear from you if you've got anything to say or want to drop me a line. And thanks again, and enjoy the rest of the night.
Fantastic. Thanks, Ben. Thank you very much, everyone, for your attendance tonight. It was wonderful to have as many people online as we did. I really enjoyed all the presentations, the presenters, as I hoped that they would be, were all fantastic. And so I'm grateful to all of them. I want to thank Luminita Vlad, who is the manager for CRE Reduce, who coordinates everything in the background. And as per usual, has done a wonderful job making this available to so many people. I'd also like to thank our sponsors through our partnership with the University Hospital of Nîmes, but also Pfizer, Baxter and Gilead. We're very grateful for your support in allowing these events to occur. So I wish you all the best for a lovely evening or day or night, wherever you may be, and look forward to joining you for one of our future webinars, which we look forward to sharing and advertising to you very soon.